Acetaminophen toxicity. So this is overdosing on Tylenol. Tylenol is found in many, many things. It's found in NyQuil. It's found in Percocet, and found in many different varieties. We got to make sure that we're not taking too much in the hospital settings. That's about 4 grams per day. You don't want to overdo it. And if they have actual liver failure, about 2 grams would be the limit for someone that has underlying liver failure. But this is someone who's overdosed on Tylenol at home usually. It's hard, it doesn't usually happen in the hospital setting, but someone that has ingested more than 32 grams is a high risk for for acute liver failure, which you just talked about, right? So how do you fix this? That's going to be Mucomist or NAC, N-acetylcysteine, and that's going to be given IV. PO can be given, but it tastes exactly like rotten eggs, so that's kind of hard to muster down, right? So usually we give it IV. Or if you see Mucomist, it's usually given as a breathing treatment, but that's not for liver failure. That's for mucus, all right? But that is it, because that's what it was originally designed for. But it still is not palatable. Either way, IV Mucomist is given, and it's dosed out in staggered doses. It starts out at a high dose, like 150 milligrams per kilo, and it goes down to 100, and they may continue it. So we can do what are called Tylenol levels. So you do Tylenol levels, and once they're less than 10, that's usually good to discontinue the Mucomist. When you also have an ALT that has subsided, right? So when we talked about ASTs and ALTs, right? So ASTs are usually Tylenol, right? And ALT would be your liver damage itself. So you want your AST, ALT to be less than, so plus AST, right? You want those guys to be less than 50, all right, which is normal range. 40, usually about 10 to 40 is normal AST, ALT. Once those are normalized and your Tylenol level is less than 10, then that is good to go. That is someone that is not going to be at risk, right? Before Mucomist can be given, or another option is to give activated charcoal. Activated charcoal is if they've, ingest within 1 to 3 hours, right? Especially if they've overdosed more than 32 grams. But who's going to tell you what the right amount is to give? Whether you give charcoal or Mucomist, or what's the timing related to? That's these guys right here, right? That's the poison control line that hasn't changed. That 1-800 number does not change, and these are experts on the line that are experts in poison overdoses, whether it be household products or medication overdoses and medication exposures. So they're the ones that give good advice, and then it's up to us to take that advice and turn it into a order, right? So advice to an order itself. So it's just a recommendation until it actually gets ordered. And usually the provider is not going to, balk at their orders. They're going to say, okay, that makes sense. We'll go ahead and do that. Okay. So how does Mucomist work? So Mucomist is adding this extra little cofactor in there. It's neutralizing this toxic NAPK. Sounds like a NASDAQ stock exchange, right? NAPK. It's a toxic metabolite that, when it builds up, leads to actual liver damage and can lead to fulminant liver failure. So we provide Mucomist, and it kind of neutralizes that for us. Normally we do our own piece to kind of neutralize out the acetaminophen byproducts, but when it's an overdose, it overruns our system's ability to neutralize the toxic metabolites. So Mucomist is there designed to neutralize those toxic metabolites, right? So what else on this, right? So monitor serial labs, monitor the Tylenol level, and you're giving Mucomist IV, right? And it should continue until Tylenol levels are negative, right? And if they start getting a lactate level that starts going up, they start getting, altered. They start getting, which is like hepatic encephalopathy kind of situation, right? That's a sign that they are getting towards liver failure or acute liver failure, and they probably need to be transported for a transplant, right? And how do you know they're transplant candidates? That's this little King's College. King's College criteria are specifically for Tylenol overdoses. We talked about the acute liver failure. There's many different criteria, Liddy's and MELDS, and the King's College. We have all kinds of different ones. King's College is specifically for Tylenol overdoses, right? They look at Tylenol levels. They look at whether they have altered level of consciousness. They look at the INR. All these things that would happen if your liver was not working, right? So a transplant eval is pretty important. So who's going to do a transplant eval? Most likely who? Most likely a GI doctor, right? GI doctor should be involved with a liver liver involvement, and if they overdose, you want them involved so they can manage it and keep track and see, and they can pull the trigger. And they got friends in high places where they can, they can say, hey, I got this patient that's, going into fulminant liver failure. Can we put them on the transplant list? Okay, or for an orthotopic liver transplant. All right, so that's the idea with with acetaminophen overdoses. It can be very, very fatal when you get more than 32 grams, right? That it can cause a lot of hepatic toxicity. Less than that, we can maybe hopefully turn them around, but looking at Tylenol levels will let us know how sick they really are. And of course, look at the AST, ALT, and look at other consequences of liver damage, your T-bili, your INR, your platelet count, etc. All right, so hepatitis, switching gears. So we talked about, acetaminophen, basically hepatitis. Your liver gets inflamed and damaged because of Tylenol. Now we're getting damaged because of viruses, right? So we have hepatitis A and E. Those are usually they are acute. They don't lead to chronic liver cirrhosis. They do lead to acute hepatitis, right? Hepatitis just being inflammation of the liver acutely, right? And then cirrhosis being a consequence of chronic inflammation, right? Whether it be ETOH, when we talk about ETOH hepatitis and ETOH cirrhosis, or Hep B, Hep C, right? Those lead to chronic liver disease, or which is otherwise known as cirrhosis, right? It's usually what's the end stage of chronic damage to the liver. So A&E, they are going to present with acute liver failure, right? That less than 26 weeks presentation of what kind of symptoms? They're going to be jaundiced, right? They're going to be jaundiced. They could have inflammation of the biliary tree. They could have pale stools maybe, but they're definitely going to be having a lot of nausea, vomiting. They're going to have malaise. They're going to have viral symptoms. This is viral, right? It's a viral illness, and they're going to feel really, really crappy, and they're going to feel they're going to look very, very jaundiced, right? So 30% are the only amount that actually develop these symptoms. So Hep A is usually not, I couldn't say innocuous, meaning that it's not something to balk at, like you'll get over it, because there's a small, like 5-10% that actually die from that 30% that actually get symptoms. So it's a significant amount, right? Like we just recently had exposure at Panda Express, and they had a significant amount of people that got exposed, right? And which percentage of those actually develop symptoms? Around 30%, right? So the ones that are younger or older or more at risk would be the ones that would end up in the hospital setting. Okay, so Hep A you can vaccinate against, so that's cool. You can vaccinate against fecal-oral transmission, right? So A and E, the vowels affect the bowels. So you have a hepatitis A is from a fecal-oral. Hepatitis E piggybacks on to hepatitis A. So it's not, you can't have E without A, basically. You can have A alone by itself, but A and E, they work together. All right, B and C, really grasping at mnemonics here. So B, blood, is secretions, right? So blood and secretions are what B and C are all about, right? Usually B is more, is going to be also a little bit of fecal-oral activity, but C is definitely with with blood-to-blood transmission. Right? They used to, I forget the age range, I think like 68 or something. That's what they say that if you had blood transfusions before this period of time, right, basically you're a boomer, and also you are at risk for hepatitis C in the blood products, right? Or in the bloodstream if they got a blood transfusion before, I forget the date, it's like 1974, 1968, there it is, 45 to 65, right? So if you've received a blood transfusion during those times, that's because they shared needles back then, right? It's like, hey, you're all done. All right, next patient, and so you're up next. So they're at risk for hepatitis C transmission, right? Another reason for Hep C transmission would be that there is IV drug use. That'd be another reason and sharing needles will be a reason to get Hep C and Hep B for that matter, because it's also a blood-borne illness. All right, so what else? So B and C lead to cirrhosis, and then cirrhosis leads to cancer. Okay, so cancer is always an end result of liver cirrhosis. Okay, what else about this? So AST, ALT, they're going to be elevated, but which can be elevated more? We talked about the viral. Again, it's one of the best I can do for that mnemonic. Viral with an L is your ALTs, right? So your ALT will be the one that's going to be prominent, right? So ALT elevation more than AST. Okay, Hep B is a little bit ridiculous, right? There's a lot of antibodies, a lot of what is it? There's antigens that you can measure. There's the core antigen, there's a surface antigen, there's the envelope antigen, there's the envelope. There's all kinds of different ones you can look at to see if someone has an active disease or a past disease, because you can be vaccinated against Hep B, right? All people that are at risk for bloodborne exposure, like ourselves as nurses, we have to get a Hep B vaccine to make sure we don't get any kind of bloodborne illness from a patient that might have Hep B. Right, so we do titers and we look to see if someone has the active infection or they are vaccinated against it. Okay, so that's what other things can you look at here. So for any of these viruses, hepatitis A virus, hepatitis B virus, hepatitis C virus, so HIV, HPV, HCV, you can look to see if someone has an active amount of the virus replicating inside their bloodstream itself, right? Because on the virus, here's your, let's say it's a mitochondria there, on the cell envelope, and also on like the Golgi apparatus inside where they make proteins and ribosomes. That's really where all the Hep C, Hep B, and HAV all kind of hang out, right? That's where they hijack your cell to make the virus to replicate themselves, right? So you can detect viral load is another way to see if someone has an active infection. So if that HIV, HPV, HCV is negative, and then you can look at core antigens and surface antigens and all the other fun antigens, and you can look at antibodies to see if you form an antibody response to it. That can tell you that you are immune or not immune. Okay, so what else on this? So you're going to get the same symptoms just like with any other liver disease. You're going to get jaundice. You're going to have a risk for liver dysfunction, right? The highest risk of being your HAV, HPV sometimes can lead to an acute presentation, but more commonly these guys lead to a cirrhotic disease process, right? And it's not just like next year; it's in 20 to 30 years that after exposure is where you're going to develop a cirrhosis. Okay, so in your 20s, if you experiment with sharing needles and such, that's going to then rear its ugly head in your 50s. That's when you're starting to get the cirrhosis to develop. Okay, all the while it was producing and replicating and damaging your liver the whole time. And of course, this is red because it's causing inflammation. Any kind of chronic inflammation can lead to cancer. Any chronic inflammation can lead to organ failure itself. Okay, so you can get chronic, you could get acute manifestations of these diseases. Hep C, it's very, very rare for that to happen, but Hep A, Hep B are the most common ones. There's Hep E, there's Hep D, there's non-A, non-B, non-C, non-D. There's all kinds of hepatitis. There's like 26 different varieties, okay? But in America, it's A through E mostly, like G is like in Asia. So there's all kinds of different ones out there. Okay, so we're not going to spend too much time on this because Hep C, Hep B, Hep A, these are all more of an outpatient thing. Patients don't come to the ICU usually with an HAV or HPV virus. That's the reason why they're here. They usually have a history of Hep C, right? And that they have Hep C cirrhosis, or they have Hep B cirrhosis, which is they're about the same 20-30%. This says 70%. It's about 20-30% development of cirrhosis in the end. All right, so moving on to another kind of hepatitis, right? So HIV, HPV hepatitis can cause your liver to inflame acutely and get, viral-like symptoms and get you into liver failure acutely. So can acetaminophen, so can ETOH, right? So ETOH, you can start drinking, and you can get acute hepatitis, right? So alcoholic hepatitis can develop just from binge drinking, for instance, or excessive drinking for a all-inclusive Caribbean cruise, right? So where you're just going to go to town, you're going to drink all the alcohol, and that can lead to alcoholic hepatitis, where your liver gets inflamed from a lot of alcohol ingestion, right? But also if you have chronic alcoholism, if you are drinking chronically more than 2 to 3 drinks per day, that could put you at risk for alcoholic hepatitis, yes, but also alcoholic cirrhosis or ETOH cirrhosis. So when someone comes in with cirrhosis to the ICU, it's you're usually betting if there's ETOH cirrhosis or Hep C cirrhosis, maybe Hep B, but those are the most common ones. Nowadays, fatty liver is rearing its head as the most more common development of cirrhosis, right? That's where you have your consequences of fatty diet and obesity. All that fat will develop around the liver. and it will start impairing liver function over time. And ETOH is a carb, right? And that carb also creates a fatty liver, right? So they call it, ETOH cirrhosis, or they call it non-alcoholic steatohepatitis. Steato being fat, right? So there's NASH, so versus, let's do another color, versus NASH, right? NASH is the alternative, where it's not alcohol that gave him cirrhosis, it was fatty lifestyle that gave him cirrhosis. Okay, so chronic alcoholism more than 5 years usually, or exposure of 6 months or more, greater than 60 grams or 40 grams. So what does that equate to? It's about 3 drinks for women, right? More than 3 drinks per day is going to put you at risk, right? And there's different grams of alcohol compared to beer versus wine versus versus liqueur, right? So patients often stop drinking like days or weeks before admission. These patients aren't the ones that come in with ETOH withdrawal. These are usually the ones that are just like, I can't drink because I'm super sick. My liver has made me really, really sick. Okay, so they feel very fatigued. They're not going to be someone that is a very, very, a very, very acute presentation, I should say. It's not a withdrawal patient, right? Usually withdrawal patients have, they're heading towards a road of cirrhosis, right? Where they get cirrhosis over time if they don't quit their drinking, right? But these patients with alcoholic cirrhosis, they're going to be chronically jaundiced. They're going to have, they might have an elevated bili, and they're going to have all the symptoms of cirrhosis, right? There's a lot of complicated cirrhosis that we'll talk about, and they're going to have that, classic ascites belly. They might have like the cava medusae. They might have a little bit of they might have jaundice too. Depends how advanced their cirrhosis is. And they'll have all the different symptoms that we see with cirrhotics. Compared to someone with like alcoholic hepatitis, they look perfectly fine. It's just now they present with acute liver dysfunction. They're going to have that acute rise in bilirubin. As the liver gets inflamed, the biliary tree gets inflamed right here. Our liver is on fire right there, and then the gallbladder on the backhand is going to get inflamed next to it, and then it's going to be very difficult for your liver to eject bili down that biliary tree, right? So it's going to get inflamed, and it's going to lead to a dramatic rise in our bilirubin, right? AST, ALT will rise. Which one will rise more? AST has to, right? So alcohol, statins, and Tylenol cause a rise in AST, right? ALT will rise too, but the ratio will be more than, more AST compared to ALT. Okay, they say about 2 times the upper limit of normal. Okay, T-bili will be high, and they're going to start losing the function of the liver, such as its synthetic function, which is making coac factors, making stimulating platelet function, and INR will start to rise with coac factors that aren't available. Okay, so ETOH cirrhosis or ETOH hepatitis, they're kind of one and the same, but hepatitis is the more acute presentation, and if they keep getting alcoholic hepatitis, they can lead to a liver cirrhosis or ETOH cirrhosis, right? So other causes that might, potentiate this, right? So someone that drinks likes to sometimes, use Tylenol, right? Or pills, and that could put them over the edge as well. So looking at someone that has, who's a drinker who also has Hep A or Hep B or Hep C, puts them also high risk of developing cirrhosis, but also they can have that concurrently. That's the reason why they're here right now. Right, and we can look to see is there something else that's causing their cirrhosis to go over the top, right? Do they have ascites? Do they have a fatty liver as well? And other infections can put especially the cirrhotic patient over the edge to be admitted for cirrhosis. Okay, so what do we do for these guys? Okay, so basically by history is really going to tell us what is going on. See if they have a ETOH consumption or not, right? So we'll talk on the next slide about how we, if it's really just truly alcohol and nothing else going on, then there's some other therapies we can do for them, such as steroids. Okay, so steroids are usually going to be given for a patient that has ETOH hepatitis, right? We give prednisolone. Okay, prednisolone does not get metabolized by the liver, so it's a great steroid to use. Right, so it's going to prevent the inflammation, right? Steroids are anti-inflammatory. This can prevent the acute inflammation for ETOH hepatitis. All right, so they might be altered, okay, because of hepatic encephalopathy. That could be the reason, and we have a treatment for that. That's lactulose, and then next treatment after that is rifaximin. They may need an NG tube to administer it, right? And usually your hepatic encephalopathy patient, they can present acutely with ETOH hepatitis, or it could be someone that's long-standing cirrhosis, One of the complications of that long-standing cirrhosis being hepatic encephalopathy, and we need to get it in them somehow, because as we'll learn with hepatic encephalopathy, is they can get present just with memory problems, sleep problems, all the way to a comatose state. So we have to get the lactulose in them somehow, right? Because there's only one place on Earth that makes ammonia. What's that? Where's the only way you make ammonia? That's only bacteria. That's the only thing in place on planet Earth that makes ammonia is bacteria. So if you get rid of the bacteria, you're not going to make ammonia. So we need to neutralize that best we can. Okay, either we give it per rectum or give it via NG tube, right? If they have ETOH withdrawal, so that's someone like ETOH hepatitis with a more of acute presentation, right? They're going to be at risk for delirium tremens, a risk for alcohol withdrawal symptoms, especially if it's been around 3 to 4 days since their last drink. And we'll talk about ETOH withdrawal in the next slide. So we're going to be giving these guys vitamins. Thiamine is usually the go-to vitamin that we're going to give. It's involved in, you can see in green here, all these different steps for breaking down glucose and breaking down fats and lipids and for energy. So if you don't have thiamine, you're not going to make a lot of ATP, you're going to be altered, right? So we need to give thiamine to prevent that for anybody that's altered, really. It's going to be very, very useful. It used to be given as a banana bag, right? So you saw banana bags ordered, and I saw it last week, unfortunately, but banana bags are antiquated. We don't do those anymore. It's like 2012, 2010, we stopped doing banana bags, right? So we don't do banana bags anymore. What we do is do IV thiamine, about 500 milligrams Q8 hours. It's high dose thiamine, right? So 100 milligrams is like the usual dose, but it's like high dose, 500 milligrams. And if you get the amount of thiamine that would be in that, it'd be about 15 banana bags, I think it is. 15 banana bags worth of thiamine is what they actually need to be therapeutic, all right? So please don't give 15 banana bags to your patient. That's 1 liter 15 times. It's going to be way too much fluid. Okay, these guys are usually malnourished, right? They are not going to be eating a lot, whether especially if they're a cirrhotic patient, they'll be very, very malnourished. So also alcoholics themselves, they have $20 to spend. They're going to spend it on the alcohol because it's a disease process where they're addicted to consuming alcohol versus consuming actual important calories and important vitamins, right? These guys aren't buying their multivitamins at Whole Foods. These guys are getting more alcohol consumption in their next drink. Okay, so multivitamins, especially which vitamin? Our thiamine is good to use. Sometimes vitamin K may be needed because these guys are malnourished. They're not intaking vitamin K. They're not eating their green leafy vegetables from Whole Foods either, right? So that's going to put them at risk for what if you don't have vitamin K? Clotting issues, right? Vitamin K is a recycler, right? You also see this guy outside Whole Foods, right? Vitamin K is like recycle your groceries, right? Recycle your cans, recycle your coag factors, right? So that's exactly what vitamin K does. It recycles the coag factors in your liver, right? Your liver makes coag factors, but it's a one-stop shop, right? You want to be able to recycle them for the next clot. So that's what vitamin K is for recycling them so that you are able to, have a sustained ability to clot. Okay, so vitamin K can be given if someone's bleeding, has bruising symptoms and such. If someone's GI bleeding, the vitamin K is going to work tomorrow because vitamin K takes 24 hours to recycle everything and do its thing in the body, right? We have to look to see, do we need to stop the bleeding immediately or do we have to, is it okay to wait? Okay, so then steroids are going to help prevent inflammation, as we mentioned. Okay, and usually it's about 7 days, 10 days or so. They might even do a whole 28-day course, but they do this Lilly score. That's something they punch in the computer and they look to see, are they tolerating steroids or not? Is their liver failure getting better or not? And do they need to be transplanted or put on a transplant list? And they look at many different things. They look to see, are they, do they have support systems? Are they at a place where they can get help after they were to get a liver transplant? And you may be thinking, well, if they drank themselves, why are we going to give them another liver? So, so these guys are, they go through frat parties or they go to, this is not someone who has chronic cirrhosis. It's someone who had made a mistake or they went overboard and drank too much. They didn't realize. So those patients can be on the liver transplant list if they develop acute liver failure. Okay, it depends on the transplant center. Some transplant centers say, no, we're not going to accept that if they are actively consuming alcohol. We want them to get better, and then we'll try again in 3 months. It's up to the transplant center, but the actual guidelines say it's okay to get them on, to a liver transplant center if they have acute liver failure symptoms. Okay, so then other things we want to be aware of is hepatorenal syndrome can happen, especially with chronic cirrhosis, and we'll talk more about hepatorenal syndrome. That's a insult to your body, puts you at risk for an insult to your kidneys, or hepatorenal syndrome, right? Especially if underlying liver disease, puts you at high risk for your kidneys to also be compromised. And the go-to medication for pretty much almost, I said, at least 3 of our major complications of cirrhosis is albumin. So albumin is usually our go-to agent you're going to see for a lot of liver patients, right? Albumin is rarely used for other stuff, right? You might see it for low blood pressure here and there, there again, but it's like the evidence tells us that it's for liver stuff, right? And then what else? We're going to look for these different scores and see if they are getting better or not. The MELD score is for end-stage liver disease. It's a model for end-stage liver disease to see if they're a risk for bouncing back or not, what their mortality risk is. And there's the Lilly score that we look at for acute alcoholic hepatitis, someone that comes in from like a hazing event at a fraternity or something. This patient would be then assessed to see are they a candidate for liver transplants. Okay, but usually it's mostly supportive nutrition therapy, and that's where we're going to start giving steroids, right? They may throw some NAC at them, some mucomist, but really it's the steroids and nutrition therapy that we're looking for. Okay, so another important thing about thiamine is that they can develop what's called Wernicke's encephalopathy. Okay, and that happens when they have a depletion of thiamine completely. Right, so we want to give them thiamine before we give them glucose as the take-home point. So glucose before glucose, right, before thiamine, because if you give the glucose first, right? Sorry, I should say that backwards. So thiamine before glucose, because if you give the glucose first, right, then that's going to utilize all the thiamine, and now we're done. Now we have Wernicke's encephalopathy. So you want to give thiamine first because that's going to then restore all the enzymes, so they're all ready to go for the glucose that we're going to give them next. Okay, so yeah, a little misspoke there, but that's the idea. Is you want to give them the thiamine first, so they have that ready to go, and they can build up whatever enzymes they need, and then we hit them up with the glucose afterwards, right? Because when someone is encephalopathic, altered, it could be low sugars, right? And liver patients, as we'll find out, as we know, it has a lot of functions. One of its functions is to raise blood sugar, break down glycogen. But with someone that has a ETOH, especially someone who is at risk from being malnourished, these guys are high risk of being depleted in thiamine. Okay, and what happens with these guys? They're going to have this. They have these ophthalmoplegias. They have nystagmus, this lateral nystagmus that occurs when they have Wernicke's encephalopathy, and it's like it doesn't just go away once they get better. It's a permanent dysfunction, right? It can lead to a permanent comatose state when you don't give the thiamine before the glucose. Okay, so that's the idea. Someone who has dementia, someone who has cachectic anorexic, someone that has ETOH are a high risk of depleting their thiamine. Thus, we have to give high dose thiamine for patients that are usually altered. Okay, so ETOH withdrawal. So this is someone who has had alcohol intake and they stopped it within the last 3 to 4 days, right? So in 3 to 4 days, by first 24, 36 hours, they might have withdrawal symptoms, and they progress to what's called delirium tremens, right? So delirium, they're delirious and they're going to be hallucinating. That's one of the key things with alcohol withdrawal is they are hallucinating. They have visual, tactile, auditory hallucinations. Tactile, they feel like ants are crawling on them. They are very, very delirious and agitated. They're usually alert otherwise, right? They're not like they have decreased mentation, like someone who has that's hyponatremic or someone that is hypercapnic, right? They are more they're clear, they're sound of mind, but they're just very, very delirious and very, very agitated. They might have a lot of nausea and vomiting. They have an SNS cascade occurring, right? So that means they're very, very wet, very, very tachypnic, they're very, very tachycardic, they're very, very diaphoretic. And then now they're hallucinating too, which is going to make the SNS response a little bit higher, right? So what does alcohol usually do? Alcohol binds to GABA receptors. And what do GABA receptors do? In the brain, they do what? they slow things down, they inhibit things, right? So the alcohol is used as like an antidepressant, you could think of it. It numbs the pain, right? So that's the idea with alcohol. It's going to numb everything. And it's going to be our GABAergic medication that we give them, right? So when you take away the alcohol, now your body is on a use it or lose it system. So it said, hey, you didn't need GABA anymore. You're taking another drug. You're taking alcohol. I'm not going to make up GABA anymore, right? So now the alcohol is left, and now we have a lot less GABA around, and it's going to be, now we have no GABA activity. We have no alcohol to suppress things, and we have no GABA to suppress things because it left, because you were taking alcohol, right? So what's left over is a huge excitatory response, and that's glutamate. That's the excitatory hormone, right? GABA inhibits glutamate. So if we don't have GABA because we didn't make our own because we lost it because we were taking alcohol, that's going to cause a SNS response, cause a tachycardic, tachypnic, diaphoretic response, right? Causing hallucinations and such. So what's the fix? Well, we can provide GABA. That would work, right? GABA will work, and GABA is not a specific drug that's just GABA. We have things that bind to GABA receptors, like propofol binds to it, and benzos will attach to it, right, and start suppressing the symptoms, right? They'll start inhibiting the symptoms. Okay, so that's the idea, is that we give benzos, but it wasn't evidence-based, right? There's no evidence that benzos are the better drug. It was only in the 70s where they had benzo salesmen that came in and said, hey, I have a new drug, it's called benzos, it will help your alcohol patients. They said, okay, they were just really good salesmen, they took them out of steak dinners, they were really great at what they did, right? And what they did before that in the 70s was give phenobarb. And phenobarb actually blocks a lot more symptoms, right? It's also GABAergic, and it blocks a lot more symptoms, and it's actually a better drug. It has more evidence behind it. But benzos, unfortunately, do not, right? So being on a benzo protocol is okay. It's going to help with some of the symptoms, but it's not helping everything. So having phenobarb is going to be a better agent if we can get it on board, because benzos can accumulate, right? How does benzos accumulate? They accumulate and they accumulate. What happens? They lead to a toxicity, right? They lead to respiratory depression, right? So it only takes about 4 grams, right? 4 to 8 grams of benzos for you to start getting respiratory depressed and stop breathing. Whereas phenobarb has a linear relationship. So just basically, phenobarb, it basically, once you reach a certain amount of phenobarb, then that's it. Now you shut down, right? So that amount is about, I think it's like 50 per kilo or something. It's a lot of phenobarb that it takes. But in the meantime, all the little smaller doses that we were giving in between are going to help with the symptoms, right? And don't have the risk of respiratory depression. The only time they do have the risk of respiratory depression is if they get a lot of phenobarb on board. Okay, so phenobarb and benzos are usually the go-to agents, right? Phenobarb is going to help prevent seizures, and seizures are a definite complication that can happen with someone that has alcohol withdrawal. Someone will say, oh, I have a history of seizures, and they say, oh, when I stopped alcohol 3 years ago. It's like, is that seizure disorder? No, that's a result of alcohol, right? They're not going to be on medications for seizures, antiepileptics, because of alcohol withdrawal back in the day. Okay, so benzos are GABAergic only, whereas a phenobarb inhibits glutamate. It also is GABAergic, so it's doing like a 2-for-1. Okay, so it is contraindicated, phenobarb, with hepatic encephalopathy. If they have an elevated ammonia as well, it's going to potentiate that, so it's not great. So that's one of the drawbacks. Okay, but reasons to avoid benzos, we've kind of talked about this a lot in respiratory, right? Can cause paradoxical agitation, delirium, right? Benzos themselves independently cause delirium, so that's not great, right? They may fail to work. They're very unpredictable on whether they are going to accumulate in fat tissue or not, and they have a very, very narrow therapeutic index, right? So they works right here, but after a while, it causes respiratory depression, right? After about 4 to 8 grams of Ativan or lorazepam, right, is one of our more common benzos that we use because it's short acting for ETOH withdrawal, right? It's unpredictable in its half-life. It wears off easily, right? It's short acting, but it's also, goes away quickly. And then it's also dissolved in propylene glycol, which can build up if you give a whole bunch of it. That's why we limit a certain amount per day of Ativan they can get, not because of respiratory depression, but because the propylene glycol toxicity, right, which leads to metabolic acidosis. All right, so it leads to metabolic acidosis. All right, so if someone has alcohol withdrawal and you give them lorazepam or you give them phenobarb, they're going to calm down. They're not going to get respiratory depression. It's usually a sign that you have alcohol withdrawal is when that the medication works, right? If the medication doesn't work, you give them like 2 milligrams of Ativan in their sleep. That means A, they wanted it. They know how to say, oh yeah, it's ants crawling. Oh, for sure. Yeah, and I'm feeling X, Y, and Z. I'm feeling really nauseous right now. They may know how to work it, but also they may know how to work it and want the Ativan. That's why they're sleeping, or they don't have alcohol withdrawal. All right, it's called non-alcoholic related delirium, or NARD. All right, so NARD is a non-alcoholic delirium. It's not because of alcohol withdrawal, it's because they are delirious, which we talked about with patients on the ventilator, with patients that are in the ICU for a prolonged period of time, right? They're just confused. They don't have tremors. Tremors are very, very key with someone that has a alcohol withdrawal. They have a tremor at rest and tremor with doing things. So they are that's a alcohol withdrawal patient. Someone that doesn't have tremors, it's like at rest or even at all, that's probably not alcohol withdrawal. That's a what? That's a NARD, right? They got a NARD in there, right? So they don't have the SNS symptoms as well. So they're not extremely hypertensive. They're not extremely diaphoretic, extremely tachycardic and tachypnic, right? So they don't have a lot of SNS symptoms. That's more of just regular delirium. They may get agitated, sure, but they're not going to have the agitation with SNS activity with extreme nausea and vomiting, extreme tremors, like an alcoholic patient would, right? So is phenobarb going to work for these patients? No. Is benzos going to work for this patient? No. It's going to make their NARD worse. All right, they're going to make them even more delirious. So we got to figure out what the underlying cause is. So just like with alcoholic withdrawals, we give symptomatic management with Precedex or Haldol or ketamine. Those abate the delirium symptoms, right, and the agitation and the SNS symptoms, but they don't actually fix alcohol withdrawal. It's the the benzo attachment, whether it be GABA attachment, whether it be benzos or phenobarb, right? Those are what are going to fix the underlying alcohol withdrawal symptoms. But as far as the other SNS symptoms, other symptoms of agitation and such, that's where we could give dexmedetomidine, ketamine, Haldol, etc., right? And those guys will work for NARD, right? Those are going to work as well. Okay, so that's the idea behind delirium tremens, which happens usually about 3 to 4 days afterwards. Again, it's progressive, where they start getting a little agitated, they get more agitated, they start getting more prominent SNS hypertension and such, where they are developing over 3 to 4 days, where they have these profound alcohol withdrawal symptoms. They may even have some of the seizure activity preceding delirium tremens, for usually about day 1 to 2 is where they get the seizure withdrawals. Okay, so that's the idea behind alcohol withdrawal, is that we are looking for where we've removed alcohol, the depressive or the inhibitory substance in our brain.